Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
It's May 1983, and we're in Ann Arbor, Michigan with Professor Rolf Frankel and Dr. Jim McNamara. Professor Frankel has been kind enough to come over and spend a couple of days with us discussing the nuances of managing the functional regulator. Rolf, I'd like to open up by asking you this question. When I first heard you talk in 1976, you emphasized the fact that the functional regulator is an orthopedic device which moves jaws and does not move teeth. What's the basis of the functional regulator?
Yes, I used all types of activators first. I inserted my first appliance in 1943, the first activator. And gradually, we used also all modifications of the activator, the open activator and the bionator, and all these types. And several years later, when I saw the results, I was not quite satisfied. I saw in particular relapses, the so-called late grouting in the mandibular anterior segment. And so, step by step, I recognized the relevance of the circumoral muscle band. And this led me to the conclusion to use the vestibule as an operational base. This was the first idea.
So the Frankel appliance uses an entirely different operational base, the vestibule,
yes.
Instead of teeth
yes.
or things inside the dental space.
Yes. I think it is the first appliance being in no contact with the teeth and operating as a functional device, as an exercise device, to first influence the muscular environment and then to expect the spontaneous adaptation of the dental-alveolar arch and the jaws.
Although I've seen many cases that you've treated, when Jim and I and Mike Durkis went to East Germany with essentially no tooth movement, there have been some recent articles that have been published that say the Frankel appliance in fact moves teeth as much or more than it moves bones. How do you explain that?
Yes. Do you refer to the article of Creekmore?
That's
the
one.
last, yes.
Or Richardson.
Or Richardson, yes. There are several articles written, but I think they talk about functional regulators, and I think the appliances used and the results analyzed in these articles have nothing to do with the use of function regulators. One sentence is mentioned in the article of Creekmore. He admits that the maxillary dentition has not been notched at that time. And this is a severe mistake. You know, you can only influence mandibular posture when the appliance is stabilized against the maxillary dentition. You must have an intermaxillary anchorage to do this. And so this is such a severe mistake, then we can talk about treatment with function regulators at all. And so another point is that the bite was, or the mandibular posture was influenced in the sense of opening.
How do you mean opening?
In the sense of mandibular backward rotation. And all our cases with high angles, with skeletal hyperdivergency, we have treated, show clearly that you can influence the rotational pattern in the sense to a closing pattern.
So, like for example, the mandibular plane angle would close with treatment. Is that
Yes,
what you're getting at?
yes, yes. And of course, it is very important to combine the use of our appliances with lip seal exercises, because our results suggest that the anterior vertical muscle chain in the lip and chin area, these muscles have an important influence on the rotational pattern, which is also suggested by the recent publications of Harvard and Thoma, who stressed the impact of the facial muscles on mandibular posture and in particular on the rotational pattern.
From an American orthodontist point of view, or certainly from my own point of view, I would say that the lip seal exercises have been the things that have had least success on a routine basis. Yeah. And I think I would like you to tell me what you would have a child in your clinic do as far as the regimen of lip exercises. How do you do it exactly?
First, we have to interest the child in his and her faces. We have to show that there is a significant improvement in facial appearance when the lips are sealed. This is the best way for motivation. And when the child is motivated to do this, it needs a reminder. And so we give the children a slip of paper marked with L, and this should be put on the school desk and should remind the child always when it looks at this slip of paper to seal the lips. All the other things are made by the exercise device in the mouth, only to remind the child to seal the lips. And another excellent tool for getting lip seal exercises is to keep a wooden spatula between the lips.
Or tongue blade.
A tongue blade,
yeah.
Yes. Between the lips to during homework and during watching television. But I have to answer another question of yours. The labial tipping of the mandibular teeth, as reported in this article as a result of function regulators, shows that the exercise device has not rightly handled. And I think that they have advanced the mandible too far forward, and then it is possible, as we experienced, that the mandibular incisors come in contact with the lingual wires and also possibly with the lingual shield. All this is not mentioned in the article, and though I can only argue that this has completely wrong handled.
Understand. That brings up the concept that I have heard you speak about yesterday and the day before about the proper amount of advancement with a functional regulator.
Yeah.
In America, we see many different opinions on how far the mandible should be advanced from the beginning, from a few millimeters to 10 millimeters, or incisors edge to edge. What is your concept on why the Frankel appliance should advance the mandible only 2 millimeters at a time? What's the basis for that?
Yes. Basically, all training work has to be made gradually. This is also used in general orthopedics. You can only have a training effect when it is initiated with caution and gradually intensified. You see this also in all sports. And therefore, when we will have an effect on mandibular posture, and training effect of the suspending muscles, we have to advance the mandible very slowly. So we advance the mandible about between 2 and 3 millimeters. That depends on the case and how easy he can advance the mandible forward by the clinical examination.
So, in other words, if you feel that if we advance the mandible too far at one time, that we are going to encourage dentoalveolar results and minimize results on the skeleton.
Yes, that's right, yes. Another point is that we think it not undangerous to change the condyle in the glenoid fossa too fast and too much. And when I used activators and we advanced the mandible very much at that time, we observed in most of the cases a discrepancy between centric occlusion and centriculation. And I think this is a very dangerous result. The so-called double bite should be avoided at any rate. And it is our experience that this can only be achieved by a gradual advancement of the mandible. And so when you advance the mandible step by step, you will never observe a double bite, a dual bite. Mm-hmm. And this is a very important effect, particularly also with concern to TMG problems.
Do you see TMJ problems very often?
No. When the appliance is made correctly and you advance the mandible gradually, we found no case where we had TMG problems during treatment or also in the retention period. We never did that. And I think this is to see in context with the stable functional position of the glenoid, of the condyle in the glenoid fossa after treatment.
How many cases have you treated in your clinic with the functional regulator?
Oh, I think about 5,000 cases. Of course, we went first many wrong ways. When you go a new way, you will make mistakes, and so gradually you find out what is the right way to get a success. But most important always is to get the training effect and to use the appliance as an exercise device. This is very important.
One of the concepts that has arisen over the last couple of days is the functional regulator as an exercise device. I know I've heard you talk about this before, but I'd say that your ideas perhaps are even becoming more clear. Do you want to talk a little bit more about that?
In mandibular resonant narcissism, the most important aim is to train the muscles suspending the mandible. Only then you can influence the mandibular rest position. And this can, as I mean, only be achieved when the mandible is not mechanically supported in an advanced position. Then the protractors have not to work. When the mandible is supported in advanced position, you cannot have any training effect on the protractor group. Therefore, we use the little lingual shield exerting pressure on the mucosa, and so we suggest that the protractors are motivated to eliminate this disturbing signal and to advance the mandible. Therefore, we should institute this therapy slowly, so that the protractors are able to maintain the mandible in its advanced position. And therefore, we ask the child to wear the appliance the first 2 months only for 2 hours in the afternoon. Then the children are able to keep the mandible in that forward position. So a training effect can be brought about.
Well, Rolf, that brings up the specific program that you use when you deliver or you provide a patient with a functional regulator. Pretend that we have a patient and you're going to give them their FR2. You ask them to wear it 2 hours per day for 2 months. Then what happens after that? How do you build them up to full-time wear?
Yes. Then gradually we increase wearing in the afternoon. We ask the child then to wear the appliance 3, 4, 5 hours. And about after 4 months wearing the appliance only at afternoon, then the child should wear the appliance at night too. And in further treatment, we ask the child to wear the appliance whole the day and at night. This the wearing will be reduced by the child always a bit. And so we are happy when the appliance is warm half a day and at night. But this must absolutely be secured. You cannot have a training at nighttime. Muscles are sleeping too, and therefore wearing at daytime is absolutely important to get a training effect.
I think you said yesterday you can't learn how to ski if you put your skis on when you go to bed at night.
Yes.
Same with the
Okay,
Frankel.
That's
Sounds
right.
like Scholl's
Yes,
method
that's
of learning to ski.
Yes. Yes. And so you cannot get a training effect when the activator is worn only at night time. And so we observed in these cases so often dual bites of minor degree, more or less, and so we were stimulated to find another way. And most important is not to support the mandible in an advanced position, but to stimulate the protractor to eliminate the pressure of the Lingfield field. This is our idea. And so we can only say we have a training effect because we have never observed a dual bite.
Mm-hmm.
As sort of a summation of this talk, I would like you to address the question of what it is that you have found that is wrong with some of the appliances that you've seen in the United States, or the kind of things that the average clinician should watch out for.
The main point is the appliance has not been used as an exercise device. And you cannot get a training effect when you advance the mandible too far forward. I think this is the most observed mistake, that the mandible is observed too much. Another point is, I have already mentioned, is that maxillary dentition has to be nudged to stabilize the appliance against the maxillary teeth interproximally. This is absolutely necessary. And another training effect should be taken into consideration. This is the draining of the circumoral muscle band, which is very important, as just shown by the investigations of Little, Warren, and Rydell, who emphasized the important role played by the circumoral muscle band on the dental alveolar development, particularly in the mandible. They observed more than 70% relapses of cases treated with edgewise, and where they had a very good result after removal of the first premolars. And I think that cannot be ignored by the American orthodontists. The late crowding in the mandibular anterior segment, and I think that a combination of fixed appliances and the function regulator in particular can prevent the relapse of the anterior mandibular segment, because we have also influenced the circumoral muscle band in structure and function by vestibular shields. And this is also an aspect which influenced me to use the vestibule as an operational basis, because you cannot influence the circumoral muscle band unless you work from the vestibule.
Well, gentlemen, thank you for your time. To summarize, I think it's important to say that Jim and I have been using the functional regulator for a number of years now. We've been to visit Professor Frankel in his clinic. We've looked at his long-term results that extend over many years, post-retention. And I think Jim and I, along with Professor Frankel, have come to the conclusion that the functional regulator is indeed a very different type of functional appliance. It's incorrect to compare it with a bionator, an activator, or a cubinator. It has a very different modus of operandus, and that is that it works from the vestibule, not from the inside of the mouth. I think we have both learned, as we've learned just in the last couple of days, that the management of this appliance includes many subtle management techniques. We hope this tape has been of help.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.